Are we good? Okay. Good afternoon, everyone. So first off, thank you so much for being here. And for those of you joining via Zoom, I welcome all of you. My name is Jay Lee. I am a faculty in the Department of Psychiatry and Biobehavioral Sciences. And along with my colleague, Dr. Alma Guerrero, I co-lead the Health Equity and Translational Social Science research team here at the David Geffen School of Medicine. Today, I'm super excited and honored to introduce our distinguished speaker, Dr. Ricky Bluthenthal. So on a personal note, when I was a graduate student at Yale many years ago, I bumped into Ricky because he was working with Professor Dr. Bob Heimer. And it was such a wonderful experience just getting to know him then and then, following his career up to now. So it's such an inspiration and really honored to introduce him today. So I'll say a few words about Dr. Bluthenthal. So Dr. Ricky Bluthenthal is the Associate Dean for Social Justice and Vice Chair for Diversity, Equity, and Inclusion, and a Distinguished Professor in the Department of Population and Public Health Sciences and the Institute of Prevention Research in the Keck School of Medicine at the University of Southern California. So he received his BA in History and Sociology from the University of California, Santa Cruz, and Master's and PhD in Sociology from the University of California, Berkeley. His research is really inspiring. He's established the effectiveness of syringe exchange programs. He tested novel interventions and strategies to reduce HIV risk and improve HIV testing among injection drug users and men who have sex with men. He documented how community conditions contribute to health disparities and also examined health policy implementation. His current studies and recent studies include an observational cohort study on how cannabis legalization impacts the use patterns and health outcomes of cannabis and opioids among people who inject drugs, and a randomized controlled trial to test the efficacy of single-session intervention to reduce injection initiation risk behaviors among established people who inject drugs. And he's such a prolific author. He co-authored nearly 200 articles and published in many peer-reviewed journals, including American Journal of Public Health, Social Science and Medicine, The Lancet, among others. And he is on the editorial boards of the International Journal of Drug Policy, Drug and Alcohol Dependence, and PLOS One. It is such an honor to have him here at UCLA, and please join me in welcoming Dr. Ricky Bluthenthal.
Excellent. All right, good afternoon. Always happy to be here, and thanks for the opportunity to speak to you. Just let you know, I treat these invited speaking opportunities as a chance to learn new things. So I'll try and just share some of my new learning with you, and then also just extended rant. So get ready. Okay, so my disclosure, so Piana study that's ending, that's the cannabis study, and then I'm working with a bunch of colleagues at USC and RAND on a variety of studies, as well as RTI. I am a sociologist. I've been sort of doing more or less the same study for over 30 years. Oh, hey, Pamina. I've conducted epidemiological studies on HIV, hepatitis C, skin and soft tissue infections and overdoses. And as Jay pointed out, I've done a lot of research on syringe service programs. The truth is that the most important thing I probably did was I helped start a needle exchange program in the 1990s in Oakland, and I helped run that for 5 years. And then I was also a board member of the initial National Harm Reduction Coalition back in the good old days. Okay, so I'm going to talk about translational research in relationship to people who use drugs and offer you maybe a novel perspective, which is to think about harm reduction as a type of community-initiated translational science. And then I'll compare it to the sort of biomedical approach that's been used to address, some of the biological challenges of being a person who uses drugs. So things like HIV, hepatitis C, overdoses. And then I'll just provide a description, a definition of structural violence and racism, and the realities that the people who have been in my studies for these 33 years face, and sort of ask the question, how can health equity and translational science help us address some of those long-term and sustained problems? Okay, so I just stole this from the NIH is clinical and translational science. These are the definitions. So this translation is this process of turning observations in the laboratory, clinic, and community into interventions. And so when I thought back to my experiences in syringe service programs and harm reduction in general, that's basically what's been going on, right? That's essentially that activity has been discovery in the community of things that work, that are sustainable and practical for populations at risk, and then trying to convince everyone for the next 3 decades that it's a good thing to do. So that's a part. And then the second part is important in terms of coming up with methods that can facilitate more rapid adoption or establish, hey, we know enough, let's get this out into the sustainability to scale part. And that's been, again, a big part of the harm reduction story in the United States. And I mean, I think it's important to keep in mind, and I'll sort of cut to the end just briefly, like every effective intervention that isn't a biomedical, like isn't a medication, every effective intervention that has dealt with the health problems faced by people who use drugs, so HIV, hepatitis C, STIs, skin and wound, soft tissue infections, etc. The most effective interventions have come from that community. It's really important to keep that in mind. I mean, I have moments in my life now when I'm at a table with a bunch of other people with PhDs and we're sort of talking about something, and I'm just asking myself, does any of us have any experience with any of these problems at all? Like, have we ever in any moment in our life been authentically hungry and not sure when we're going to eat again, or unhoused, or using a substance that if we don't get another dose of it in 4 hours or 5 hours, we're going to become very ill, right? And so I think part of my key message is we need a lot more cultural humility, and we need to recognize that most of the problems that people have in this country, they actually know the solution to. We just have to give them the resources and create a permission structure and a politics that support actually doing the things that work for them. And so much of what happens at NIH, and I've been in this a long time, it's not a distraction, but it's definitely not addressing the real needs of people who have health problems. And it would be great to imagine a world where that was changed. So a boy can dream. All right, so harm reduction as an example of community translational science. So these are just some tenets of harm reduction. I usually, sort of reduce these to 4 things, and hopefully I'll remember them now. So, client-directed, practical, non-punitive, non-judgmental, and then collaborative, right? I mean, one of the things, and I'm going to talk about this later, but one of the things I like about the health equity frame is that it contemplates a world where we're giving people who have a difference the resources to have the same experience as everyone else is. And that's really important to keep in mind, right? There's a lot of focus in our lives even around process, and it's a process fair, but like we don't start at the same starting line, right? So particularly in health, where, the whole medical care system, it just as a patient, is bananas, right? And it's predicated on scarcity. I had a situation where someone in my family needed to get an appointment in the USC system. And it was like, okay, you can get an appointment, 6 weeks or 6 months, so then I had to use hey, I'm in the system and I have this title and things, and email some people so that they could get taken care of. But like, is that a system of care? Right. And that's not, something that's unique to USC. That's structure, right? We create that scarcity on purpose. And then, that has differential impacts on people, right? So upper middle class, educated, Ricky with a title in a medical school, it's not a problem, right? But if I'm not in that circumstance, it becomes a big problem. And God help you if you don't have great insurance to begin with, right? So we accept these taken for granted that are structurally unequal, and then are surprised when things don't get better. right? Or we're like, oh, the patients need to be more savvy, or they need a patient navigator. It's like, yeah, that'd be nice. But the truth is, we should design systems that provide care to people, regardless of the amount of money associated with that patient. If we want to improve health, just a thought. All right. So HIV was the thing that, at least in the United States, got harm reduction going. And what I'm just trying to show you in this little, if you follow the arrows, they go down and then to the side and then up, it's just how the community of people at risk have consistently come up with effective interventions to deal with the problems they face. So in the case of people who inject drugs, HIV happens, they say, hey, we need syringe service programs. Then hepatitis C jumps off. Then, okay, let's begin giving out cooker and cotton filters that might reduce the spread of hepatitis C. Then the overdose crisis, naloxone, right, by Dan Biggs. I mean, I was in the room, thankful, I'm honored to say, when he just sort of showed up at a harm reduction meeting with a bag full of naloxone. It's like, hey, we should be giving this to our people, right, in the 90s. And I remember thinking, with all of my education and insight, wow, that sounds, I don't know, somehow dangerous and yucky, right? Because my training doesn't prepare me to like accept, oh yeah, that's an amazing idea. And we should be doing it, right? And 20 years later, everyone agrees with Dan, right? And so this goes on. So now we have this problem with fentanyl. We're actually creating laws that get in the way of that, right? So, one of the things is I was thinking ruefully to myself about my prior R01, which was on this preventing injection initiation. And it turns out it's easy to do that in LA, you just give out fentanyl, which is what's happened. So many of the people who used to inject drugs have now transitioned into smoking fentanyl. We should be providing them with pipes, not to facilitate so much the fentanyl consumption part of it, but to recognize that injection drug use is more dangerous than smoking. And then, lastly, we're at this situation where the combination of people being unhoused and, xylazine being introduced into the illicit drug market is creating these horrific wounds that are slow to heal. And, when people are living outside, they're not getting the 3 to 4 to 5 weeks they need for their skin to recover from these kinds of infections. So there are a variety of things. You could say safe supply, you could also say housing. And then let me just say a word about safe supply real quickly, because I know it's very controversial. So safer supply basically just refers to giving people who are have chronic substance use disorder, let's just say related to opiates, giving them a legal supply of that drug. That's what safe supply is, right? As opposed to the illicit supply that they're getting in. And the advantages of safe supply are numerous. And it's been studied. So it's actually, we have good evidence that it works. And essentially what it does is it substitutes an unknown foreign object, right, substance that has God knows what's in it, for something that's produced in a safe pharmaceutical way. When people are given that option of safe supply, generally speaking, their use goes down and the chaos in their life goes down and their employment goes up and their connections to family goes up and their housing stability goes up. And the take home is kind of like, yeah, if we give people the things that they need, they will be better off for it, right? And I know that that's a reach, but that principle is really true. And I'll talk about this a little bit, about the substitutes for safe supply, which would be methadone and buprenorphine, which we've systematically made hard for people to get, right? So again, there's a way in which the solutions are there. We could be using them and we just sort of don't want it. Mostly for political purposes. So this is just a summary of the sort of impacts of these different interventions on the kind of ailments that people face. And because I have too many slides, I'll go through this quickly. All right, and we've seen great success. So one of the nice things I've observed in my life, aside from legalization of gay marriage and a Black president, has been the acceptance of harm reduction at a federal level. Again, it's as I'm about to point out, it's beginning to recede a little bit. But there've been real improvements, and obviously syringe service programs are a big part of naloxone distribution in the United States. And people are using them to do a bunch of other things, helping folks with wound care, getting people into substance use treatment, helping people with housing, so on and so forth. But we're it's always going to be politically tenuous. As we've seen in Oregon, the Measure 110 was rolled back. San Francisco, which had been sort of the Valhalla of harm reduction for decades, is now doing drug testing for people to receive general relief and pushing for compulsory substance use treatment. There's been preemptive prohibition of syringe service programs in some California rural counties. Defunding of syringe service programs in Philadelphia. I could go on. There are a bunch of different things that are happening. And then even this approval of care courts narrowly, again, I've been doing this a long time. I've literally spoken to tens of thousands of people who use drugs. They are well aware of the challenges they face. They don't need a kick in the butt or an obligation to get into drug treatment. If we want them to get into drug treatment, we should make it as easy to do as getting illicit substances, which we've never done, right? But that's the paradigm. Like, saturate the community with the good thing you want them to do, and people will make use of that. All right, so some of the limitations, obviously the political vulnerability, underfunding. There are also questions, and this is a sort of insider baseball thing, about adherence to harm reduction principles. So like those 4 things I outlined, like I believe them to the core of my soul. I'll die on that mountain, literally. Lots of people get jobs, they do this work, they may not be in that space, right? But we want people to get in that space where they recognize human autonomy, dignity can be satisfied and uplifted when we give people the resources they need to obtain them. And then dissemination has been slow, right? So if we're thinking again, that translational model, look, the first needle exchange program was developed in Amsterdam in the 80s, right? For hepatitis B. Like, imagine a world where that gets widely and globally disseminated within 4 or 5 years. And we have a different epidemiological profile, right? Around HIV, around hepatitis C, or even things like hepatitis A. Like, we could have had an enormous impact on a global pandemic. But oh, it worked? Well, let's do pilots. Well, the pilots work? Oh, well, let's try and do a randomized, well, we can't do a randomized controlled trial because we know enough that we know it doesn't work. But let's put these rules around it, and let's slow walk it. And then decades later, and literally hundreds of thousands of deaths, right? You say, okay, maybe this isn't a bad idea. Like, if someone I cared about was on the receiving end of that kind of treatment, I would be furious every day. In fact, I am, right? So there's just, and I'll just make a quick aside, like, there's nothing on the other side about not doing these programs. So what do I mean by that? There's no harm in doing them that is greater than the harm of not doing them. There's no lesson that you're going to learn by not doing them that you didn't already know beforehand, right? It's just getting in the way of us keeping people healthy. So just keep that in mind. Like, we're not, and I get in these conversations with journalists, and they ask me, why are people opposed to needle exchange programs? I'm like, I do not know. Like, you should ask them that question, right? What I can tell you is, if you do it, you will save a lot of people's lives, you will reduce human harm, and you will uplift human dignity. And if you don't do it, we see what happens when you don't do it. Hundreds of thousands of dollars, hundreds of thousands of deaths, people needlessly incarcerated, families disrupted and broken up, communities underinvested in and destroyed. Those are all choices, right? And so this sort of thinking about, like, hey, we have some principles of harm reduction that we could probably, in a translational science world, like, just begin applying to a whole bunch of different areas and issues and watch what happens. And in fact, I'll point out some places where we're doing that, and it's the same thing. It's getting slow walked, right? So you just get success after success after success, and then the center doesn't move. The other thing that drives me batty is the money thing. So I dislike cost benefit analysis for a whole set of separate reasons. But one of those reasons, a new set of reasons, is this question of harm reduction will always save you money. It's sustainable. It's inexpensive. It's underfunded. And not doing it is crazy expensive, right? So you think about the decriminalization that they've sort of taken away in Oregon. So now you go from, oh, we're not arresting people, so now we're going to start arresting a bunch of people, right? Incarceration is expensive, and it does not improve human health or human well-being. It just doesn't. Having police intervene in people's lives is not good for them, right? And there are studies in the criminology literature about like just contact with police is unhelpful to people's social and health progression, right? It's not a positive institution. And it's expensive. So, we have these sort of options available to us, and we need to sort of proceed. So let me do a little bit of happy talk now about the biomedical interventions. And I do mean happy talk. So the time I've been doing this stuff, I've seen great, incredible gains that can help individuals with a whole set of health problems. And it looks like, they're going to continue to be more and more of them, right? So when I started back in 1991, there was no effective treatment for HIV, right? We can now treat HIV effectively, and we've been doing it since 1996. The original regimens were complicated. They're now single pills. We had no way of biomedically preventing HIV transmission. We now can do that easily, and those medications are easier to take. So 1 pill a day, there's shots now. These long class of long-acting medications are past development now. They're probably available. This is a slide that's 3 or 4 years old. We've had methadone available for a long time. It's the most heavily regulated substance in the United States still. I mean, there are new regulations that are coming online soon. I think it's October, that will make methadone a little bit easier for people to get. But it's still, well, there are a couple of things. So it's still hard to get. And it also has there's a feature of methadone where there's a well-established state-level regulatory system that methadone is subject to. And that state-level bureaucratic infrastructure is a real impediment, right? And it's not evidence-based. It's not driven by patient needs. It's just some person deciding who gets methadone, right? Based on something. I'm not sure what it is. And then buprenorphine wasn't available. It is now widely available. We still have the problem. It's underprescribed. We have an embattled primary care system. So asking primary care physicians to add this to the many things that they're already doing when they're already oversubscribed probably wasn't the best idea. But we'll continue to make progress, and certainly coming out of COVID in Los Angeles in particular, I could speak to, buprenorphine through telehealth is now available at many of the needle exchange programs. So, and that's a way for people to get it. Now, the problem with buprenorphine, and this will get to one of the things that I'll say a little bit later, is that if you're a person who chronically uses opiates, it's not always a great drug for you. Right? So it can be hard to start. Methadone feels better than buprenorphine does. So those are some of the complaints, right? So, and we see this a lot, even in other areas, like there are these long-acting psychiatric medicines. As someone without a psychiatric problem, they sound like a great idea. But if you have one of those disorders, saying I'm going to feel one way for a month, like you think about that. Like if someone said, hey, you're just going to feel one way all month long, that's not entirely what the experience is, but that's a lot of it. Like there are whole things you won't be able to feel for a month. I don't know. I'd be a little queasy about agreeing to do that as well. And that'll get to a point I make later, which is that these things would all be so much better if we talk to patients who were disadvantaged or low income or struggling to use them, if we talk to them first about what would work for them, right? You know, a lot of these things make a ton of sense to me. And I have problems, but not really, right? So it's like I'm the last person you need to ask about whether something makes sense. And so we could routinize, again, in a sort of translational science way, make it routine in medication development to be talking to the patients who need the medication most first and discovering what's going to work for them. Because if you have something that works for the person who's most disadvantaged, guess what? The people who are doing okay are going to be fine with it, right? And they're going to be able to use it as well. And instead, we kind of do it the other way. So it's like, what's the bolus population that has money, you know, the Venn diagram of has money or good insurance and has this ailment. And we'll, you know, that's the bullseye we want to hit for the medication. And so then we act surprised when it doesn't work for other populations. And so that's sort of what's happened with some of this stuff, you know, in HIV, the pre-exposure stuff, you know, it's just not that popular with people who use drugs. You know, we know we haven't done a great job of getting it to African-American men and American Indian folks. And if we start with them first and then develop the medication, it's going to work for white gay men. Right? But if we do it just for people who are resourced, it tends to not work for people who don't have resources or who have structural vulnerabilities. These are choices we're making. We don't have to do stuff the way we've been doing it, right? Like we could do it differently. And I would argue we would have better results. And this is just sort of more stuff, bringing home that point. All right, so we have these biomedical strategies, which are amazing. You know, they're not COVID vaccine amazing, but they're just below it, just below it. And, you know, mad props to the people who developed these things. But we've never put together an infrastructure that would get these to the people who need them most. And we continue to have regulations, both regulations and then sort of economic incentives that make it difficult for these systems to provide the care to the people who need it, right? And that should make you furious. That's a choice. We do not have to do that. But we make that choice at every study section. We make that choice at every training session. We make that choice at every Congress or state level government. We're constantly choosing to make the world harder for people who need the most help for no good reason. All right, so this leads us to the structural violence piece. These are just definitions. One is by UCLA's own Philippe Bourgoy, you know, talking about these systems that result in unequal risk of disease for people based on these sort of disfavored statuses. So whether it's you're African-American or American Indian, or you're a person who uses heroin or methamphetamines, we've really done a great job of discriminating against people, making our care systems toxic to them, making many treatment centers toxic to them. And those are choices, and those are systems, and we can change those systems if we choose to. And then you'll all get the slides. This is just a great slide that was developed by my colleague, Andrew Sick, at the University of Washington. Look up the article, it's actually really good. And she takes it through a bunch of different groups. I just put the one up here for African American. But you know, these processes, Jim Crow, continued segregation, microaggressions in predominantly white institutions, mass incarceration, like these are the kinds of things that destroy people, right? And make it difficult for folks to achieve wellness. It's the same version for Hispanic or Latinx people. And so one of the things that these do, and I'm going to take you through some dissertation research I did, which is when I was on sabbatical, what I was supposed to be working on, but was not able to revisit, but boy can dream. So this is a picture of Oakland, which is right here. And redlining was this process the federal government began in the 1930s, where they basically went through neighborhoods and based on their demographic characteristic, assigned a risk level to them. So if you were a red area, no one wanted to give you loans. That's basically the take home, right? And if you're a green area, you're probably a white area, and you could get lower interest loans, right? So below market rate. And so what that ended up doing is, how many people in here own a house? All right, so for those of you who don't own a house, let me just tell you, if you own a house and you don't do substantial repairs that probably are equal to about 20% of what you bought the house for every 10 years, your house will disintegrate. That's just physics. And so in places like West Oakland, where there was long years of disinvestment, when I began doing my work there in 1991, there was abandoned houses all over the place because people weren't building up equity. So they didn't have access to money. Plus, they were in this racialized economic hierarchy, right? So they didn't have great jobs. They weren't getting raises regularly. And so their houses fall apart, right? And so because of that, then you have these other things come in. So, all right, so let's put a water treatment plant there. And let's put the steel plant there. And we'll have the port go right through this neighborhood. And then, oh yeah, this area is really bad. So let's do slum clearance. And then the kicker is, hey, we need a freeway. So let's just build it right through the middle of the freeway, right? So you're displacing families and then you're breaking up community cohesion, right? And so then when I, plod along, let me just skip ahead, and we begin doing this HIV epidemiological work in the early 90s, it turns out these neighborhoods that have been subject to this sort of persistent disinvestment and assault, have higher rates of HIV, right? And then you look at that, it's even higher for African Americans. Now, because of our racial psychosis in this country, when I began doing this work, everyone was telling me, oh, that's because Black people are riskier than other people, right? It's an individual problem. I don't know, you all are crazy, right? You don't care. You're just out there doing stuff, right? So let's look at that. So we collected a bunch of data from people in West Oakland and Richmond, and you're a public health group, so you know what this means. So basically what this logistic regression model is showing you is that actually African Americans were lower risk than the white folks in the study, right? And then we had a decent model because things that you would think predict HIV still do. So shooting gallery use, crack, being unhoused, injecting heroin. And so when you look at the neighborhoods, you have these differences, but it looks like what's happening is more a neighborhood phenomenon, not a race phenomenon, right? So whites in West Oakland have an elevated rate. Blacks in Central East Oakland or Fruitville neighborhood have a lower rate, right? So it wasn't race, it wasn't individual behavior, it was context. It was a context that we created with our policy. Also, war on drugs. So we did some studies that just sort of show even being worried about getting arrested for having syringes leads to greater HIV sharing. It had a huge impact on operating the programs when they were illegal. Police aren't helping, right? That's not their job. Their job is not to prevent HIV, and they prove that every day, right? So, we need other approaches to help folks. And so this is just sort of the summary then when you look at these neighborhoods and what explains the differences in HIV rates. And, you have this sort of abandoned housing situation that facilitates social network interconnections between drug networks. You have an open drug market versus a closed one. Weak informal social control because you disrupted the natural sort of community connections that people have with your freeway. And then this physical setting, right? That's literally driven by redlining and hazardous industry. All right, so let's look at a current case, and I'll go through these even more quickly. The basic take home, and this is sort of what I've been thinking about, not the most, maybe the most, the last 10 years, is just that as great as harm reduction is, and as much as it shows us a way forward, it can't overcome basic political economic realities, right? So if you're unhoused, and this is everywhere in the world, your risk of getting HIV and hepatitis C is about twice as high, right? And these are sort of two studies that look at that. And then what's happened in the time when I've been in LA, so I've been in Los Angeles since 1997, 98, 97, 98, since 98. And my studies, you see the homelessness has sort of increased. And now our last study was about 85%. And this is happening in other places. So that's a study from Chicago, sort of finding the same thing. And so we began looking at the impacts of displacement, right? And there's actually a really deep literature, both in medical anthropology and in sociology, about displacement. So you just think about refugees, right? Or asylum seekers. Like that kind of fundamental disruption of the human community is tough for people, right? So people who are unhoused and who use substances in Los Angeles, in this case, Denver, most of them are unhoused. And then most of them are displaced on a regular basis, right? And so we've begun looking at the impact this has on folks' risk profiles and their access to other services. So this is on subsistence issues, including some health issues. And you see a strong, relatively, positive relationship between overdosing and moving, right? Sharing syringes and displacement. And then you have these other basic things that we all need, also getting worse as people get moved around more often, right? So like our policy, and there's just a report out this, I neglected to put in the slide, but 4118, I think the city controller, Mejia, is that his name? They found the report, they released it, and it's like nobody got housed, it cost a fortune, and it just made people's lives worse, right? That's our normal politics in operation. All right, and then exposure to violence is higher, and then people are losing things they need, right? So food, clothing, syringes, naloxone, even buprenorphine, right? That stuff's getting thrown away in these sweeps. And so it's not surprising to see that that's related. It ends up being related to greater odds of overdose, greater odds of syringe sharing, and then just your basic ability to take care of yourself is being reduced. So, we have a policy that's actively taking people who are all already wildly disadvantaged, traumatized, subject to the worst sort of interactions that humans can have, and we're making their lives worse. And then we're surprised things don't improve. Right? It literally makes no sense. Like you would do this if you wanted to destroy a people. This is what you would do. Right? That's what the Nazis did. Right? I mean, this is a little controversial, but that's what they did. They uprooted the people they didn't like. Right? They put them in places that were unfamiliar, and then they starved them for basic resources. That's our routine policy for unhoused people. And so this is just making that point, more on that point. All right, so these structural conditions are profound. They lead to multiple health outcomes. They destroy individuals' capacity to take care of themselves. And we're not really addressing them, right? So this is some of the limits of the science. And when you think about this, right, we have this problem where we like to focus on individual behavior. And let's be honest, because it's easier to measure. We don't engage enough with populations that are at risk because we have fancy educations and we don't believe people actually have insights into their own lives. And let's face it, addressing these fundamental causes would require us to do things differently, all of us, something that we all need to do. All right, so, but we can reimagine, right, a world where that's not necessarily the case. So the great thing, and this is like that standard health equity, and I'll be done in 5 minutes, that standard health equity kind of thing, where, right, you could have an equal process, or, you can have a circumstance where people get what they need. Right? And we kind of do that in some areas. I mean, we do not great, but we're okay on the disability surfaces, right? And like if you walk around, I get to travel a fair bit. So, you're in another country, the things you don't see that you take for granted in this country, like the low sidewalks, right? For people in wheelchairs, or making sure that there's a ramp to get into buildings. Like, that's a big deal. That's a good thing that we did, right? We just need to expand that thinking to a whole range of other people who have needs. But that could be easily satisfied at a societal level without a ton of resources in all likelihood. And then I think in the case of the groups that I'm interested in, because helping them is so much more cost effective than hurting them, we probably make our money back in the long run. So that, so those groups I'm interested in aren't sort of included in the sort of disabilities framework, although there are efforts now, legal efforts to make that the case. So places where folks have inadequate access, for instance, to medication for opioid treatment, there's a possibility of using lawsuits to sort of change the sort of availability of those services. The other thing is that we don't engage in politics, right? So all of these things that I've talked about that I find so disturbing, they're political choices, right? That we vote for this stuff. And we can take a different approach. So the first thing would be for people like us, to really engage with patients and at-risk populations at a much deeper level than we routinely do, right? So if we're working with them and partnering with them and coming up with solutions for the worst off of folks facing these various health problems, again, I will contend that if we solve it for the worst off, we have solved it for everyone, right? So it could be a real boost to our capacity to actually deal with national epidemics that we have around hepatitis C and infection and skin and soft tissue infections. And I'll give you some examples. We need to take advantage of when there are changes in our society that give us a chance to look at health benefits that are novel, right? And I'll give you some quick examples of that. And then when we're designing these things, we need to take into account that there will always be backlash, right? I mean, it's hard to know what to do about it, but knowing it's coming is probably a better choice than waiting for it to happen. All right. So in terms of the folks I work with, so people who use drugs, there's a growing, use of CBPR methods with these groups. There's also drug user organizing happening. And then one of the great things is that a lot of people are finding their way into the workforce. So they have regular jobs and have routine ways of contributing to study designs or coming up with innovative ways to address problems that they face. These are just two papers that provide examples of them. All right. And then in LA, we've had some cool stuff happen that maybe we're not taking it, including myself, not taking advantage of as much as we should. So we had this Measure J that passed, that's still working on getting implemented, about creating a care infrastructure for at-risk youth and communities. Obviously, housing first, and there have been some good studies done at UCLA and USC on this topic. The universal basic income, we had a small experiment in LA that Ben Hindwood led. The results of that have come out and they're very positive. People's lives improving, bad things not happening. And then there's this other thing, and this is sort of happening in Hollywood right now, this Trieste model. And the basic idea, although that's not what's happening, they're not doing this precisely in Hollywood right now, but the original model was, you sort of set aside $10,000 for a person who has a severe mental illness, and then they get to spend that money in collaboration with a caseworker, right? And you get amazing improvements both in their mental health, but also in all the other conditions of their life. So we need to sort of be more aggressive about looking at ways to evaluate these so that we can disseminate them more broadly. That's just detail on Measure J. This is some information on the Trieste model. All right. And then the last thing is, we've got to start addressing these determinants of health, right? So, and I think I can say this confidently, the more economic inequality that you have in a society, the more health problems you have, right? That's been observed over and over and over again, right? So this idea of racing resources up to the top 1% or top, 0.1% is not a recipe for a healthy society. And at the same time, you know, we need to put more effort in giving people the basics, right? I mean, we're seeing this now even in education, where a lot of communities are now sort of just providing free breakfast and lunch to everybody because they realize kids who are well fed learn better, right? It's really it's really straightforward. Like, it's not, there are, you know, there's this idea that there are good people and bad people. And if I'm being honest with myself, like, I don't think there probably are some bad people, and there probably are very few authentically good people. Most of us are in the middle, right? And we're responsive to the stimulus that we have in our environment. And if we have more positive stimulus that provide us with resources and opportunities to be better people, we generally will be better people, right? So, you know, we could do a lot of this stuff. We just have to change our story about ourselves. Right? All right. So translational science can contribute to improvements in health and well-being. Translational scientists need to consider the social context for the health problems and the medical problems that they're trying to address. And that if we can begin to accept and then account for these structural inequities, we're probably on the way to having a science that will actually help us improve human health overall. Thank you for your attention. I'm happy to answer questions.
Questions from the audience?
No, Pamina had her hand up. Well, or Nina.
Oh, can you just speak a little, I have lots of questions, but can you speak a little bit more to the methadone and the idea of it? Maybe, I think you allude to maybe it's actually better, right? And that these other,
Oh, in terms of from the perspective of people who use drugs?
right, then the really what I feel like is being promoted, and maybe especially promoted to well-off people now, is bupe.
Mhm.
But maybe for the drugs itself, not the way we make people take them, methadone may be better. And could you just speak, what do you know, or what do people tell you about that? Or am I not understanding it right?
No, you're understanding right. I mean, I would summarize it this way. I mean, even if you took out how hard it is to get methadone, right? So let's say you made methadone and buprenorphine equally available. Many people would prefer methadone because they can feel better on methadone, right? So taking methadone makes you feel, you know, not a ton, but a little euphoric, right? And if you want to later in the day use a drug, you can do that. Whereas it's a little bit more, I mean, people have learned how to use buprenorphine in a way that will allow them to use drugs later in the day, but not everyone knows it. And so it's that kind of thing. Like, it's just, people want to have control over their lives, right? And you know, how you feel, like, I feel good most of the time, so I don't even think about it. But like, if you're in a situation where you don't feel good all the time, or you have a chronic health problem or chronic pain, like being able, and most of the people in my studies do have chronic pain, like serious chronic pain. Like, we just did a chronic pain scale paper or abstract, and like half of them have some kind of chronic pain, and most of that half have like grade 4, like serious disabling pain. So not having a capacity to change how you feel in relationship to that is a big deal. And again, that's the kind of thing, like I didn't figure that out. Like, I didn't think my way through that, right? I just asked people, and then you're like, holy crap, like, this is a real problem. And I've been doing this forever. Like, so I'm always discovering new things. Where like, oh yeah, if you had been just talking to people, you would have understood why these problems persist the way they do. Yeah, Pamina?
I'm loud. Always great to hear you and always inspiring. And so the one thing is, I think you probably all saw there was an article yesterday in the LA Times about methamphetamine here in Los Angeles and how it's just not going away and it's a persistent problem. Right? So many of these strategies that you presented were for people who inject drugs. But while we have people who use methamphetamine who inject drugs, like you said, with fentanyl and all that, and we're working on an analysis now, looking at sort of the trajectory of injection, which is more nuanced than we expected, that people come in and out of it. What is there for people who use methamphetamine, in your opinion, knowing that neither methadone, buprenorphine, really work. Syringe exchange, if you're not like,
Mhm.
that feels like a gap.
Oh,
And I
yeah.
don't know if you have, you and I have talked about drug checking, and I'm coming around you. I'm not convinced either that this is such a great real harm reduction approach.
Mhm.
So what are other tools that you see coming that can help for these drugs that we have that are not injected?
Yeah, well, we should talk to the people who use them. I think the things that we have available immediately at hand are contingency management for people who are interested in slowing down or stopping. And there are policy, I mean, we could have it statewide, but our governor decided that we didn't deserve that. So that's one thing. I mean, I think we would have to work closely. I mean, there were some studies, and you may be aware of these, during COVID in Canada, when people were housed, some of them were given access to sort of, I think it's high dose Adderall as a substitute for meth use. So that's something to think about. I mean, the truth is that already happens, right? So you have a diversion issue related to Adderall and retinol. I said that close enough, you know what I mean? So, but I think we need more, we need translational science. Like, we need to talk to people. I mean, people like Kathy Reebok, I know, and perhaps Steve Shoptaw have had conversations with folks who are regular meth users about ways to use it to get the effects that you want, but then use it in a way that you don't get all the negative effects that come for sort of prolonged use. So I think engagement, but and some of that engagement has to begin with the fact that people have good reasons for using them, right? So in my studies, which are mostly people who have chronic opiate use disorder, lots of them use fentanyl because they're also unhoused and it's unsafe. So people are using fentanyl during the day and then using meth at night so they can stay awake and not get jumped or assaulted or have their things taken. Right. So maybe if we had better social determinants of health and people were housed, there would be more of the regular utilitarian meth use that we used to have like in the 70s and 80s, right? So it was about, hey, I'm a roofer. This is boring, dangerous work that's uncomfortable. Meth helps me get through that day, right? Or, yeah, I want to have sex, and this stuff feels great when you're having sex. But we have people now using it just to make it through the night. And we could probably eliminate that part of it. So maybe break it up into pieces, engage with the community, and they could probably help us come up with some solutions, or we can come up with solutions together. Yeah. Tom? Good to see you.
Ricky, nice to see you. I'll preface this by begging your pardon because I have to get across the street in a few minutes for an oral exam. But you said a great many things that I agreed with about the importance of considering social structures that will help us, that we're making choices. Something you said that I disagreed with was when you said that there was no good reason for people to, for some of these choices. I think there are good reasons that people have that don't have anything to do with racism, that have to do with their public policy considerations. And I was just wondering whether there might be a legal status that you would embrace or would be open to where people might opt into a scenario that might be sort of the legal equivalent of being on probation, where they would opt into in exchange for getting guaranteed income and access to safe supply, that they would accept a legal status that if they engaged in other illegal activity, they would then, it would be like the legal status of probation or something like that, that would then enhance the negative consequences downstream but it would maybe be a structure that would be in between, sort of to deal with some of the legal gray areas without society just embracing safe supply in a way that would be abhorrent to a lot of people. I'm just curious how you would react in general to.
No, that's a terrific question. So let me deal with the first half of it. So look, we're rationalization machines, right? We can come up with reasons for everything. What I meant to suggest, and it's not that people who disagree with what I want to do are racist. I don't think, I think many of them aren't, right? So it's not that. It's an unwillingness to weigh the alternatives. So let's use an example. Where I live in Silver Lake, there are homeless encampments around the neighborhood. I see homeless people on my way to work. I see encampments on my way to work. You know, that causes discomfort. That makes some people feel unsafe, right? I get that. And maybe because of that, you want to sweep that encampment. But when I tell you sweeping that encampment is going to devastate the people that you're doing that to without getting them housing, I would hope that you would weigh your queasiness, your fear against this is actually doing harm to people. And so then to get to your second point, I would, like, we have lots of ways of influencing each other, right? We're all in families that we were influenced by and we've influenced them. We're all in communities that we influence our neighbors and they've influenced us. There are lots of consensual ways to get people to the place that you want them to be in without holding incarceration or withdrawal of love or benefits from them. And I think those methods are more efficient in general, all things being equal, than creating a legal regime that creates different classes of people, which is what we've done, right, with our mass incarceration and what's happened with these folks. So, I mean, maybe is there like a 1% group out there that they need a high, or 2% or 5% that they need a highly structured relationship to get to a better place? That I'm open to that, but I wouldn't start with that. You know, I would start with, hey, everyone's got a house. Here's where you can eat. Here's access to job training. Here's access to medical care. Here's access to, you know, safe supply or whatever, so that you're not, you know, bothering my neighbors in Silver Lake. Right. So that's the thing. And I think that account that we can, like, there's a city council member who used to live near me. Unfortunately, he's passed, but for some reason, he started talking to me about homelessness. And he's a good guy. He's like not a bad person, but he's like, oh, they just need a kick in the ass. And it's like, when I said to him, it's like, they're getting kicked in the ass every day. Like that. So, you know, what they don't have is resources and easy pathways to get where you want them to go. And that's what that's how I would reply. So I don't think, you know, again, we're all in the middle as far as I'm concerned. We're capable of great harm and great good. And we're sort of deciding that balance every day. I think if we had a political culture, though, that we understood that, look, that my children have done well, right? And they've done well because their mother and I have spent a ton of emotional and material effort on making sure that they're as good as we can make them, right? And create a world that is as loving and full of possibility for them as anyone else, right? We could do that for everyone. We just create, you know, because of structural racism, because of stigma, because of, you know, bad ideas of how you actually change people's behavior, we don't. And then we blame them when their outcomes aren't great. So that's sort of how I'm coming from. So I appreciate that.
Ricky, thank you so much. So I know that we're at time, but I just wanted to maybe your final thoughts. There's a question from the Zoom audience.
Okay.
So hoping to get your thoughts about how the heightened integration of community patient perspectives in translational science potentiates action on the systemic barriers that impact uptake of interventions. More specifically, to get those contested interventions disseminated and into the use more broadly.
I almost want you to say it again. What, is it just me?
I'm just reading it. So
Is there a simpler version of that question?
I think the integration of incorporating community and patient perspectives, does it facilitate action to remediate systemic barriers?
Yeah, gotcha. Okay, I'm good. So I think what they're asking is if we had a system where we're routinely empowering patients and communities at disadvantage, would that have an impact on the structural possibilities? And I think the answer is yes. I mean, you know, if you look at the communities that are doing these universal basic income, the political attributes of those communities, it's because they have different kinds of indigenous leaders now who have a sense, right, that outcomes are driven by resources, not by the individual constituents of people, right? Like we're all going to land somewhere in the continuum, but the truth is, if you have more resources and those resources are positive, you will do better. And if you have disproportionate contact with negative ones, like child protective services, like police, you know, you're truant officers, you're going to be worse off. Yeah, so I think it's all part of a, you know, and I didn't put this in this, but, you know, I wrote a paper with some of the amazing local community organizers in Los Angeles about that sort of connection between abolition and harm reduction. And the truth is, you know, as a scientist, we should be engaged with communities, and we should be engaged with the politics of those communities in a way to help us create sort of healthier conditions. So before I finish, let me say, sorry for bringing up the Nazi thing. It just sort of occurred to me in the moment. But it, you know, I think it's important to realize that displacement is something that humans do to other humans all the time, and it's always negative. So that's the point I'm trying to make. You bring the Nazi thing just so people get that, yeah, that's a bad thing to do. So no equivalence, just making a point about this sort of policy.
All right. Well, thank you so much, Ricky. This was so inspiring and really, you know, like energizing for all of us. So
Okay.
really appreciate you.
My pleasure. Thanks.